Welcome, medical students, to today's lecture on autosomal dominant polycystic kidney disease, ADPKD. In this comprehensive script, we will delve into the genetic basis, pathogenesis, clinical presentation, diagnostic imaging, complications, management, counseling and genetic testing, polycystin complex, cellular mechanisms of cyst growth, renal fibrosis, molecular signaling pathways, impact on extrarenal organs, and conclude with a summary of the key points covered. So, let's begin our journey into the world of ADPKD. ADPKD is inherited in an autosomal dominant pattern. PKD1 gene mutations, 85% of cases, on chromosome 16 and PKD2 gene mutations, 15% of cases, on chromosome 4 lead to abnormal cellular proliferation, fluid secretion, and kidney cyst formation. Severity varies based on gene mutation and modifiers. Autosomal dominant polycystic kidney disease, ADPKD, involves complex cellular and molecular mechanisms. Disruption of polycystin proteins leads to abnormal cellular processes, resulting in cyst expansion and renal dysfunction. This is caused by abnormal fluid secretion, reabsorption, and tubule stretching. ADPKD is usually symptom-free until adulthood. Common symptoms include flank pain, hematuria, urinary tract infections, hypertension, and enlarged kidneys causing abdominal fullness. Disease progression varies but can lead to chronic kidney disease and potentially require renal replacement therapy. Other organ systems, like the liver, brain, heart, and valves, may also be affected. Early surveillance and intervention are necessary to address these complications effectively. Diagnostic imaging is important for diagnosing and monitoring autosomal dominant polycystic kidney disease, ADPKD. Ultrasound is the main tool used, as it is non-invasive, cost-effective, and widely available. It can detect cysts and other abnormalities. In some cases, CT scans or MRI may be needed for further evaluation. Monitoring with imaging helps track disease progression, treatment response, and complications. In autosomal dominant polycystic kidney disease, ADPKD, various complications can occur, affecting kidney function and overall health. These complications include kidney insufficiency, stones, bleeding or infection in cysts, high blood pressure, cardiovascular problems, and liver cyst complications. Factors like gene mutation, age, gender, and blood pressure control influence the risk of developing these complications. Identifying and managing these issues promptly is vital for better patient outcomes and preserving kidney function. The management of ADPKD focuses on slowing disease progression and managing complications. This includes controlling blood pressure, following a low-sodium diet, and promoting physical activity. Pharmacological therapies may be used for specific indications. Regular monitoring and addressing psychological and social aspects are also important. Genetic counseling plays a crucial role in ADPKD management. It provides patients and their families with information about the inheritance pattern, genetic testing options, disease prognosis, and family planning considerations. Genetic testing can help confirm the diagnosis of ADPKD, identify at-risk individuals, and facilitate early intervention and surveillance. Counseling should also address psychosocial aspects, such as emotional support, coping strategies, and facilitating peer support or patient advocacy groups. Open communication and empathetic guidance are essential in empowering patients and enabling informed decision-making. The polycystin complex consists of polycystin 1, encoded by the PKD1 gene, and polycystin 2, encoded by the PKD2 gene. Polycystin 1 is a large transmembrane protein with various functional domains, including extracellular, transmembrane, and intracellular regions. Polycystin 2 is a calcium-permeable ion channel that forms a complex with polycystin 1. The polycystin complex participates in cell-cell and cell matrix interactions, signal transduction, regulation of ion transport, and cellular polarization. Dysfunction of the polycystin complex disrupts these critical functions, contributing to cyst formation and disease progression. Cyst growth in ADPKD is driven by abnormal cellular proliferation and fluid secretion within renal tubules. Mutations in the PKD1 and PKD2 genes affect various cellular processes involved in cell cycle regulation, apoptosis, cell proliferation, and differentiation. Additionally, disrupted calcium signaling, cyclic AMP-dependent pathways, and mechanosensation lead to dysregulated fluid secretion, resulting in fluid accumulation and cyst expansion. Understanding these cellular mechanisms is vital for the development of targeted therapeutic interventions aimed at inhibiting cyst growth. Renal fibrosis, characterized by excessive deposition of extracellular matrix components, is a hallmark of ADPKD progression. Multiple signaling cascades, including transforming growth factor beta, TGF-beta, WNT/beta-catenin, and mammalian target of rapamycin, mTOR, pathways, interact to promote fibroblast activation, myofibroblast differentiation, and collagen synthesis. Crosstalk between cyst epithelial cells, interstitial fibroblasts, and inflammatory cells further amplifies the fibrotic response. Strategies targeting these pathways or modulating the fibrotic microenvironment hold promise as potential therapeutic approaches to delay or prevent disease progression. ADPKT involves dysregulation of multiple signaling pathways, leading to cyst growth and renal fibrosis. Abnormal polycystin function disrupts calcium signaling, activates cyclic AMP-dependent pathways, and affects cell proliferation, differentiation, and apoptosis. Potential therapeutic targets include vasopressin V2 receptor antagonists, mTOR inhibitors, somatostatin analogs, and stem cell-based therapies. Further research is needed to assess their safety, efficacy, and long-term benefits in ADPKT management. In autosomal dominant polycystic kidney disease, ADPKT, there are multiple organ involvements. The liver is often affected with cysts that may lead to complications. Regular screening for intracranial aneurysms is necessary. Cardiovascular abnormalities, pancreas, spleen, intestines, and reproductive organs can also be affected. A comprehensive screening approach is crucial for effective management. In conclusion, autosomal dominant polycystic kidney disease is a complex genetic disorder with significant implications for renal health. Understanding its genetic basis, clinical presentation, complications, and management strategies will be crucial for your medical careers. Thank you for your attention.